My talk is titled periprostate joint infection following primary total knee arthroplasty. Sorry, let me just go full. Following primary total knee arthroplasty, a 15-year population-based cohort, and it's funny because I almost was late to this talk because I was just doing that exact surgery of an infected total knee. So it's a very common and relevant issue. I would like to just briefly mention that I am presenting this on behalf of the McMaster Arthroplasty Collaborative and some of the key team members, including Dr. Kim Madden, who's on this call, and Dr. Anthony Dilly, who's the Chief of Surgery at St. Joe's. So we'll get right into it. Those are my disclosures, grant funding from these organizations. To start, basically, total knee replacement is the gold standard treatment for end-stage arthritis of the knee. And in its most simple form, it involves these three components: the two metal components and the middle component, which is made of polyethylene, which basically mimics cartilage and allows the patient to have a functional knee and to remove their arthritic pain. Like I said, it's a gold standard for osteoarthritis. It's a very common surgery, and it's increasing every year. There were over 70,000 of them done in Canada last year, and that represented about a 25% increase in volumes compared to 5 years prior to that. And the trend is projected to continue to rise as we get an aging population and as people try to stay active later into life. It's also a very reliable surgery, somewhere between 80 and 85%, maybe even a bit higher. Patients when they go to the surgery are very happy with the surgery and have a much better quality of life, and and their pain is taken away, which, you know, if you compare that to a lot of things we do in medicine or in surgery, it's an extremely high success rate. The issue is one of the most devastating and common complications after total knee arthroplasty is what we call a periprostate joint infection. Basically, when bacteria get into the joint, and depending on the type of bacteria, some of them can actually form this thing called a biofilm. So they get onto the metal components and they form basically a protective layer around themselves, which prevents, which means that the infection can't be cleared with simple IV antibiotics, and almost always requires another surgery if the patient is fit enough for surgery. Requires us to go back in, and which is, like I said, what we just did is go back in, give it a full washout, and usually take the components out and put in new ones. In a surgeon of arthroplasty surgeons, it was named to be the most concerning complication. It has a huge impact on patients because it means multiple surgeries, IV antibiotics at home, months of rehab that they weren't expecting from what is usually a very reliable surgery. The risk is probably somewhere around 1%. It varies if you look at database studies versus randomized control trials, and there's some obvious reasons for that I won't get into, but it's probably, the 1 year risk is somewhere around 1%. Lifetime risk is probably somewhere between 1 to 3%. And it's the number one cause of revision total knee replacement in Canada. And so it's, even though it's a small percentage of them that get an infection, it's still the number one cause of us having to go back in and do surgery. And it has an impact on our economic system. So each revision knee surgery costs on average 80% higher than its counterpart primary knee surgery. And that has obvious impacts for a single payer public healthcare system. So the purpose of our study was to use just doing a presentation, 10 minutes, sorry. Okay. Based on a population-based database, the ISIS database, to determine the incidence of PJI after primary total knee arthroplasty, to examine trends in the rates of PJI over the past 15 years, and to determine risk factors for PJI in this population. The methods we use, like I said, we use the ISIS database, which looked at primary total knee replacements between January 1st, 2002 and December 2016 in patients over the age of 50. And we looked at some patient demographics, operative details, and discharge status. We used time to event analysis, specifically Kaplan-Meier survival curves and log rank comparisons, and a Cox proportional hazard regression model. The descriptive data, there were about 130,000 patients over the age of 50. 61% were female, 19% were diabetic. Cumulative risk of PJI at various time intervals started at 0.5 at the 1 year mark, which is a bit lower than what we found in the literature, and up to 1.65% at 10 years. Over half of these were diagnosed in the first 2 years, and the median time to PJI was 1.5 years after surgery. Looking at temporal trends over the past 15 years, we found that regardless of which time point we started with, there was a relative decrease in the risk of PJI. So basically, surgeries that were done more recently had a lower risk of PJI, and the relative decrease was about 4.6% for each subsequent year. The risk factors that we identified based on our regression analysis were male sex, diabetes, post-traumatic arthritis, discharge to convalescent care, and patellar resurfacing. So that's when we also replaced the patella, which is something that used to be routine and is done much less frequently nowadays. As you can see, the hazard ratio is essentially can be interpreted very similar to an odds ratio, except that it's time-based. And male sex, as you can see, was the strongest risk factor there. And just to show you the survival curves for diabetic and non-diabetic patients, you can see the diabetic patients in blue had a significantly higher risk of PJI throughout the time of the study, but particularly in the early period compared to non-diabetic patients. So to summarize, we identified these 5 risk factors: male sex, diagnosis of diabetes, patellar resurfacing, post-traumatic arthritis, and discharge to convalescent care. Cumulative 10-year risk was 1.65%, and the overall trends show a slight decrease in PJI rates, which is encouraging, but it still remains the #1 cause of revision surgery in total knees. And future steps from here are basically to try to figure out how to drive that infection rate down further. And so we're working on actually setting up a trial led out of McMaster to look at some intraoperative interventions that can potentially reduce rates of PJI. That's my presentation, and I'm happy to take any questions. Thank you.